You are live now, doctor.
Okay, great. Ready, Mudit?
Yeah. All right. So good evening, everyone. Thank you so much for joining us today for the felicitation of winners for the image and video competition by VRSI. And I think this is a very interesting program which has been running for the last more than 30 months and a very good platform for all of us to submit our interesting images. We have got as a country such a huge amount of clinical data and such amazing cases and images. I think it's a wonderful place for all of us to share our images, learn from each other, and the entire imaging committee, including Dr. Chitranjan, Dr. Unnisa, Dr. Naresh, and Dr. Vinod, are doing such an amazing job in not only encouraging everyone but also in taking care of this entire process and sharing such great images with all of us. We also today have a great panel, including Dr. Mahesh, sir, Dr. Muthu Krishnan, and Dr. Santosh. And I think I will not take much time. I'll directly hand over to Naresh sir and Unni sir to please introduce and take forward the proceedings. And thank you so much for joining us. This is every third month we will be having our image and video competition. So the sequence will be something like medical grand rounds 1 month, followed by surgical, followed by the image and video competition. So thank you so much, and on to you, Unni sir and Naresh sir.
Thank you, Dr. Mudit. Actually, after we were talking about 30th month, I remember, I think 24 months in the first session, 24 months in the second session, and this is 2 months in the third session. So I think we are in the 50th month of
50th month, my
Correct,
apologies.
yes,
correct.
50th month uninterrupted, actually. Uninterrupted 50th month of this imaging. Actually, Chitran, we should have celebrated, we missed the landmark.
Yeah, yeah, yeah.
Yeah,
Correct,
so
sir.
again, welcome all the, what do you call, the winners. So the format will be explained by Chitranjan. And as we keep telling, we don't have any rights over your images. So you send as much as possible. And in case if you want to publish it in any of the journals, it is fine. So it is free. And before handing over to Chitranjan, one last word. See, we all know that everybody is thankful. So please don't thank I'm talking about the winners. Don't thank A to Z actually. Just get into the business directly because you have got only 1 minute to explain your slides. Over to you, Chito.
Thanks, Naresh sir and Mudit. And may I request Unni sir to please also tell a few words about the competition that we are doing. Then we'll start the award presentation.
So
Unni
I've
sir.
been very honored to be a part of this for the last quite a few months. And I mean, one thing I'd like to say is that the images we are getting are fabulous, but as an imaging competition, we are not only looking for the diagnosis. We should be looking at the quality of the image, and the technology and the expertise used to take the image also should come to the fore. So it is not just about a cute name to the image. It is about the quality of the diagnosis, the technique used to image the process. And we should, and all our future entries, we would love that those proficiency in taking the image and capturing something special should also come out. Over to you, Chitra.
Thanks, Sunni sir. So all of us, we agree that it's not only the scientific part, but also the photographic and some amount of philosophical terms that Mahesh sir was saying in giving the captions to the images. That is also important. So with this, in this episode, we will felicitate all the winners of the months of January, February, and March 2026. To start with the January month, and the third prize for the month of January goes to Dr. Giriraj Vibhute. Dr. Giriraj is VR consultant in MMJCI Hospital, Hubli, and this is the beautiful award-winning image which he has captioned as "Frozen in Time: The Portrait of Persistent Fetal Vasculature," and this is the literature he has described for this image. And may I request Dr. Giriraj to please say a few words about this image, Dr. Giriraj.
Yes, sir. This image was captured using the Zeiss Claris photography technique, which is the ultra wide field photography image. This is a picture of a fundus of 19-year-old amblyopic girl. This is shows the persistent fetal vasculature. It is due to failure of regression of fetal vessels in this eye, and it is the second most common cause of infantile leukocoria. And these children are prone to develop amblyopia, cataract, glaucoma, and retinal detachment. So differentiating this from retinoblastoma is important in these cases, and counseling is also important.
Thanks, Dr. Giriraj. So with this, we'll move to our panel, Dr. Mahesh or Dr. Muthu. I think Dr. Santosh is yet to join. So what are your views on this image? And simple straight question will be like when to operate or not to operate these kind of eyes.
Before that, this similar picture you can get in ROP equally also, but that is entirely different. This Falsamo fold and this sort of picture you can get in ROP equally also. But this is a classic picture of persistent fetal. Initially, we were telling persistent hyperplastic primary vitreous, right? Persistent hyaloid
Yes,
artery. But this is the, yeah. I don't know because the prognosis will be bad because many of these cases will have, I mean, from birth, there will be structurally the macula will be altered. I'm not sure, I have not operated as such, but there are some cases where it is anterior persistent fetal vasculature where there is cataract with anterior vessels are there. So those cases, lensectomy, vitrectomy at a very early stage with the amblyopia treatment is very useful. Those cases, the posterior persistent fetal vasculature, usually we don't touch unless there is some TRD or retinal detachment. They can get all sort of complications, glaucoma, retinal detachment, etc. Yeah.
Yeah, correct, sir. Points very well taken. Any points from our image committee members, Unis sir, Naresh sir?
Then these people will have some 360 or 460. If we operate, I think we'll be that vision also. So better not to touch it actually.
Yeah, correct.
This anterior vitrectomy, I mean, this lensectomy with anterior vitrectomy is done for pediatric cataracts. Some of them will have this anterior fetal vasculature. It can even bleed sometimes.
Yeah.
That anterior. I've seen it. Yeah.
So one of the techniques that was described is not to trace the stalk and cut the stalk to the disc, but just disconnect it from the back of the lens and do the procedure.
Yeah.
So that is not, do not allow the dissection to go close to the disc, or even a cauterizing a bleeding vessel could be a catastrophe.
Yeah. So overall, very challenging situation, and we should always weigh whether we are going to get any benefit or not. So point is very well taken, and again, congratulations to Dr. Giriraj. He gets the certificate and 2,000 rupees as award. Yeah, continue and keep it up.
Yes.
So with this, we'll move to the second winner, Dr. Mihir. Dr.
Hello,
Mihir, yeah, he is consultant in Lilavati Hospital and Research Center, All Cure Super Specialty Hospital and Gulmore Eye Clinic in Mumbai. And this is the beautiful image which he has captioned as firewall of myelin. And this is the description he has given, Dr. Mihir. And may I request Dr. Mihir to please describe this image?
Yes, sir. So this is a case of, am I audible, sir?
Yes, very much. Please continue.
So this is a case of Stratsma syndrome. So what happens in this syndrome is that there is a triad of unilateral high myopia, intense myelination of nerve fibers, and anisometropic amblyopia. So there is no surgical treatment required for this. This is just intense myelination, and SD-OCT or a spectral domain OCT also tells us that thickening of the myelin layers. So what happens is there is amblyopia which needs to be managed with full cycloplegic refraction, and sometimes it can be associated with nystagmus too. Occlusion therapy and all that, if it is done in the early stages, then the vision loss can be prevented.
So very straightforward you have told, but a very simple case. But the syndrome that you told recently, I think ophthalmology retina or somewhere it has been published. So maybe some of us would have come across to that also. So great. Yeah. Any like further comments on this by any of the panel, Muthukrishnan?
Yes, sir. Very interesting picture of extensive myelinated nerve fiber. It is very unusual that it's so extensive. And yeah, as he said, Stratsma syndrome. It's a common association that myelinated nerve fiber is associated with myopia and amblyopia nystagmus, all that. So it's just a fancy name for this Stratmas syndrome. Another syndrome is Gapo syndrome. All these can be ruled out in extensive myelination. And in due course of time, if we observe absence or disappearance of myelinated nerve fiber, it's an indicator for demyelinating diseases, optic neuritis, multiple sclerosis, and so on. So, very interesting picture. Thank you.
Yeah, the
Thank
last
you.
one that you told, Muthukrishnan, actually, we were asked by Naresh sir during our fellowship so many times, what is the correlation of this myelinated nerve fiber with optic neuritis and demyelination. So if this patient develops optic neuritis, this myelination will be gone.
I think
So
I have one.
learning
I have one question.
Yeah.
yeah,
Actually, usually these people will have myopia not very high, -4 or 5, but the vision will be very bad. Unlike a unilateral myope without myelinated nerve fiber, why this myelination causes that much amblyopia? I was just thinking, any reasons anywhere? I could not find out why. Because saying -4 in one eye, vision may improve to 6/12, but this will have only 3/60 and all sometimes.
yes.
Severe amblyopia.
Usually,
That is,
I would like to say something, sir. Usually,
yeah.
this myelination is depending on where it is categorized into 3 types. If the myelination is attached to the disc, then it has a poorer prognosis. And if it is on both the arcades and encroaches on the macula, the prognosis becomes poorer.
So myelination, extensive myelination, it has been associated with enlarged blind spots also on field analysis. That is point number one. And point number two is that definitely it is not just the presence of myelin, there is a structural abnormality of the RNFL layers also contributing to visual loss. So I was just saying that this is a beautiful case for a first year ophthalmology PG to learn the direction of the nerve fibers. You can see curving from the
Yes.
macula, going from the macula, everything is wonderfully seen here. And probably we can understand that the papillomacular bundle being affected, that the two regions being affected could be one reason for a poorer visual acuity also.
Yeah.
Was the OCT done in this case?
Yes, the OCT was done, sir. It showed intense myelination and the thickening of the nerve fibers. And because they were so thick, there was some amount of backshadowing, which made the layers of the underlying retina, the layers which were underneath
OCT of the
it, to be
macula, I mean
more
to say.
different.
OCT of the
OCT of
macula.
passing through the fovea, it was okay. It was not so bad, but passing through where it was myelinated, the underlying layers couldn't be seen because of backshadowing.
So just to think of any correlation between like foveal thinning or so, because of poor vision we are discussing right now. Just I wanted to know.
Okay.
So with this, for all our viewers, the audience, very subtle or seemingly very, trivial kind of thing that can be having so much of extensive discussion. So everything is having science in it. So again, congratulations, Dr. Mihir, and he gets a certificate and 3,000 rupees for this beautiful image. And again,
Thank
we
you, sir.
welcome, Dr. Santosh, our third panel. He has joined recently. And with this, we come to the first winner, Dr. Grishma. Dr. Grishma is a VR fellow in Chaitanya Hospital, Trivandrum. And this is the award-winning image, fundus caldera. She has put it as fundus caldera. It's a case of choroidal detachment. And this is the description she has put it over here. May I request Dr. Grishma to please say a few words about this image.
Good evening, sir. Actually, this was taken with Optos Whitefield fundus imaging, and he was a 65-year-old gentleman who had a history of trauma. So he presented to us with this picture, actually a double detachment, both retinal and choroidal detachment. And as you can see, the floor forms like a volcanic summit with the raised edges. So that's why I have given it the name of fundus caldera. Thank you, sir.
Correct. So what about the management, Dr. Grishma? Do you want to say something about the management? How did you manage this case?
Yes, sir. We actually gave him a trial of oral steroids and had advised surgery. Unfortunately, he did not turn up for further follow-ups.
Okay. So we'll go to Dr. Santosh. Like, what will be your preferred, plan of action for this case?
No, as he said, because we have both CD and RD, it
Yeah.
is always better to have a systemic course of steroid, and just
Mhm.
after the CD is little subside, it will be easier for the VS surgery. So it is always advisable to uh, uh, give a course of steroid and take the patient for surgery, so that you can deal the case very easily. And the central fundus is here is well seen. So sometimes you may need to drain the CD, but in this case, I think we can take the patient with a course of steroid.
Correct. So steroid, CD drainage, and buccal, PFCL, and two-stage surgery. Many things to be discussed. Before I come to
Yeah.
Naresh sir regarding two-stage, may I request Unni sir and Mahesh sir to please say their views on the management of this case.
So,
Actually, yeah, Uni, please.
no, please.
This sort of picture we see in trauma. In trauma, where there is a cyclodialysis or hypotony is there, we can get this sort of choroidals with exudative RD also. We are not. I mean, I didn't see any break here. So that is one thing. In post filtering surgery, hypotony also you can get this sort of thing. UVL effusion syndrome, we can get this sort of picture. We see this sort of multiple choroidal, peripheral choroidal with RD. So as the management always, it is rule out
Yes.
hypotony and then oral steroids and then see whether there is any break and then go inside, not immediately go inside because some may be exudative. Yes.
So the posterior pole being attached does not mean this is a primary surgical case where you do plan on one step on two step. The first is a gonioscopy, cyclodialysis cleft, assessing whether there is occult leakage, and then the steroids. Now the steroids is a point of change. If the RD increases with steroids, that means the choroidals have been buckling a break somewhere, and when the choroidals go back, the RD develops a reg RD. If the exudative component totally, that is the choroidal and the RD component goes away, then you know that it is the more exudative component. But if it is a hypotony as the main cause, dealing with the cause of the hypotony would be the primary treatment modality over there. So you have a diversion of three things: hypotony, RD, which is tamponaded by a sudden hypotony choroidal, and the third is a pure exudative phenomena. So a divergence will happen between these three once the steroids go in and a differentiation is made.
Correct. Good.
So, how
So
long are you giving steroids, Dr. Unni?
So, see, steroids is not going to be a thing. It is in a week or 10 days, we might have an answer as to what is happening. There is one more school of thought now. Now, a lot of people do active drainage of the choroidals, and they don't want the choroidals to be too shallow before it is drained also. But that is a different thing. But I would say that if in the presence of hypertony, steroids are not the only way. But if there is no hypotony and this picture is there, then I would say in 7 to 10 days, we should have a flattening or a reduction in steroids.
So, in case if you're finding a break in this case, I'm
Yes.
just saying any dialysis or something, why not surgery in the first place?
No,
That
that is,
is
I mean,
perfect.
that
Yeah.
is if we see, that is if you're seeing a break.
Yeah,
No, then it does not become an unexplained choroidal or hypertony. No,
exactly.
it
Yeah.
is a reason of the choroidal and hypertony. Here, one of the main points is that the posterior pole is attached, and obviously the decision making is based on not seeing a break.
Yes.
correct.
But the
So
problem is
point.
prolonged PD also is a provocative factor for PVR
Yeah.
changes.
Yep.
Yeah. So point is very well taken over here. We have to rule out the causes of hypotony or exudative RD or trauma. Then if it is a surgical case, then we should not wait very long, even though we can plan for steroid. So we have also Dr. Vinod with us. He has joined. Welcome, Vinod sir. And your thoughts on this case?
Thank you, Chitranjan, for having me here. Sorry, I missed the initial part. But if it is a case where I can see a break, probably I think it should be laserable. So if you can see the break well, I'll just probably laser it and maybe add a gas bubble, and that will do the case. Very recently, I came across a case who had a retinal detachment. I posted him on the surgery. When I went in with the surgery next day, surprisingly, the patient had developed a CD in the area of the brake, and CD was buckling the brake. So there was no RD on table. So I just did some core vitrectomy, lasered the brake, and put did air fluid exchange. Did not even put gas bubble, and that did the trick. So as I think Dr. Unni explained it very well. If it is, you can see the brake, then it's very easy case. If you suspect there is PVD and then RD which has led to this, I think tobacco dusting would be a good sign to look for in this case. If there is some break, it will give you a good clue whether there is break or not. But if the vitreous is absolutely clear, then one has to rule out other causes of hypotony leading to CD. And probably I think another cause which we need to rule out, if the everything else fits in, is uveal effusion syndrome, which can sometimes present with peripheral CD.
Okay. Sir, Vinod sir, just to ask a question, like in your case, you told even tamponade, oil tamponade is not needed, or it was not needed in your case?
It was a superior brake. When I went in, the CD developed, which has buckled the brake. All the fluid had gone. Just trimmed the HST's, horn, and did some core vitrectomy, lasered the brake, and did air fluid exchange. Nothing else.
Okay, great. So we had a great discussion on this particular image. So I'll just add one thing to the photographic aspect of this image. We have seen the previous, the persistent fetal vasculature. I'll just go in the interest of the audience. We have many, younger colleagues. So please have a look. I don't have any financial interest though. Yeah. Where it is. So if you can see this image, the elevated part of the image is having some kind of artifacts. The lines you can see over here. It's not about not focusing. Even if you focus the posterior and the retina, the elevated part is kind of, having some artifacts over there. However, that was Clarus. And if you can see this pseudo color, the Optos image, the one we had extensive discussion over here. This one, you can see the elevated parts are relatively clear over there. So meaning if we have the point of interest in two planes in Optos, the Optos one is having slightly better hand in giving some clarity and avoiding the artifacts over there. No financial interest though. So with this again, we congratulate Dr. Grishma. She wins the first prize and 5,000 rupees for this beautiful image. Congratulations, it's party time in Chaitanya, Trivandrum. So then we move to the winners of the month of February, and the third prize goes to Dr. Apurva Chandana. Dr. Apurva is VR Fellow in Arvind Hospital, Chennai, and this is the image which she has captioned as Fall of the Crimson Dome, and this is the description that Dr. Apurva has given for this image. May I request Dr. Apurva to please describe the image.
Yes, thank you, sir. Good evening, sir. This is a 30-year-old male who was presented to the OPD with a sudden painless loss of vision, unilateral. On history, the patient gave history of trauma by a 1-year-old kid with the fist on the eye. And on examination, we found the sub-ILM bleed. The patient was taken up for NDI hyalotomy on the same day. This photo is ultra wide field photo taken on Zeiss Claris. The laser was done on Pascal, a double frequency NDI laser, 532 nm. Parameters used here were power used 500, spot size 50, and duration 50. On the most dependent area in Delhi, we had given 2 laser spots that stretch the ILM, and then in the center, which lead to drainage. The
I think she has disconnected.
Yeah. Dr. Apurva?
I think she got disconnected.
Yeah. Please unmute. Please unmute. Unmute, Dr. Apurva.
Yes, sir. Am I audible now?
Yes, yes.
Yes, sir. So the presenting visual acuity was 5/60, and 1 month post follow-up, the visual acuity was 6/9. Thank you, sir.
Correct. Thank you, Dr. Apurva. So, with this, we'll go to Dr. Muthukrishnan. Dr. Muthukrishnan, what are your views on the management and the presentation of this case? Muthukrishnan.
Yes, sir. Quite a straightforward case. Valsalva retinopathy managed with NDAG hyalotomy, and good to see complete resolution with some vitreous hemorrhage. And what about SF6 injection along with this to hasten resolution?
Yeah.
If the blood is clotted, then we can use Muthukrishnan. This is a very fresh blood, no?
Yes, sir.
Hyalotomy draining nicely. I think we don't need actually. Chito, can I make a point?
Yes, sir. Please, sir.
Yes. So we have published something called inverse drainage,
Mhm.
especially the lower margin of the PRH or the subilum bleed is straddling the fovea. It is very dangerous because there are reports of macular hole forming. In such cases, we go to the non-dependent area, either superiorly or laterally. We'll make a hyalotomy and then inject gas, and that evacuates all the blood. I think this we published as inverse drainage for subilum bleed, number one. And number two, actually, Chitranjan will be remembering the subilum bleed when it comes into the subhilar space makes another nice boat-shaped image. I think
Yeah.
our image is there in the payments cover page actually,
Cover
in
page
case
of payment.
somebody wants to see that.
Yeah.
We have
Correct,
done
sir.
a hyalotomy long time back. So we can
Yeah.
see two boards actually, one in the subhilar space, the other one in the subhilar space.
Yeah.
Yes, so the classical double ring sign.
Double link. So,
Right.
yeah, before I come to Dr. Vinod about the Arcus retinalis thing, which is something, a novel thing which they have published. Before that, Mahesh sir or Dr. Santosh.
Yeah, actually, Dr. Apurva said LD at 532 nanometer. Is it green laser? FD at frequency double D laser was used here?
Yes.
Green
Yes, yes.
laser.
Or frequency double D, green laser?
Yes, sir.
Okay. That is what 532 user. See, we this ordinary 1064 NDR also we can use. There are some technical things that I would like to suggest. There are four dots of aiming beam when you give the YAG hylodotomy. Actually, the lower part is little curved. It's a dome-shaped area. So it is to make all the four into one before firing. It is little difficult. So you may have to slightly tilt the that contact lens up and little you have to tilt the eye little up. Then only it may become. So in one shot you can drain it. That is regarding the technique of doing this. Number two, I have also done one case. The upper part I gave on and asked them to lie down on the left side. So it also drained because the lowermost dependent part was at the fovea. So little above and laterally I did and then asked them to lie down on the left, I mean other side, opposite side. So it drained. So depending on the location of the this thing, you can always. Then the gas injection usually we combine only if there is a subretinal or sub ILM. Only premacular hemorrhage we don't advise gas injection. Okay, Jit. Right.
Yeah. Dr. Santosh.
Yes, I have a point to make. What is the maximum duration in terms of days where one should try doing a hyalotomy? Because we have a series which is usually in literature it is 2 weeks, but we have seen in more than 12 cases that on the uh, the leisure day, it may not bleed profusely if it is clotted. But when the patient comes for follow-up after a week or so, there is definitely decrease in amount of blood. So I would like to take opinion of the expert panel regarding this.
Yes, Santosh, after doing the hyalotomy, we are in the second floor. We usually ask the patient to go up and down for some 4 or 5 times. That also exerts some this thing so that the blood drains. And as you said, yes, if it's slightly clotted blood, yes, fine. Within a week, it at least the macular area clears. And if you do OCT in such a stage, actually that ILM will mimic like a CSR in these cases.
So
Right.
one small point I want to add to the newer people doing when the point of laser, always you have to think of the distance between the retina. That is one key point. Never at a point which you think is too shallow. And the
Closer to
second
this.
thing, yeah, and the second beautiful point here, if you look at the right-hand side image, always take into consideration, you can see the levels. In this, you see three levels. One, the level of the cellular blood elements. Above that, you see a level where the fluid is more, the red color fluid is more. And then above, you see the part where it has actually the circle, the level has settled down. So lasering into the cellular elements may sometimes not allow a proper drainage. If it is purely into that hypopion type of level, it may not drain properly. So when you plan a point, try not to be at the level where you see only cellular elements, because the hole in the hyaloid may get blocked.
Correct. So great points. So I'll move to Dr. Binod regarding straightforward regarding the Arcus retinalis that you have published in European Journal of Ophthalmology.
I think I will like to make 2-3 points rather single one. So
Okay.
thanks for reading that article, Arcus retinalis. So if you see the preoperative picture, so you can see the white line, which is there on the temporal aspect of the hemorrhage. Now, if you run your OCT scan through that particular line, you will see a vertical peg-like structure on a B scan, and that usually kind of tends to disappear once the hemorrhage goes away. So this is an indicator of subialam hemorrhage, apart from the usual indicators we saw. Now that is one thing. Second, there are some retinal hemorrhages here, so that is little unusual for Valsalva retinopathy. That is two. The multiple small retinal hemorrhages which are there. Third, I think Dr. Mahesh talked about it. It's difficult to make 4 spots of the laser beam into one. So one simple trick is use a Goldman 3 mirror lens. Okay, so this is one condition where I always use Goldman 3 mirror lens. I know availability is an issue, but making into 4 points into one is much easier with Goldman 3 mirror lens. And I think the real fun starts, I think where we all stop, but the real fun starts once you have drained the fluid and do the OCT next day. Now there is a beautiful, you can say a premacular cavity which forms, and usually you can run your raster and you will see hole in the ILM or the posterior hyaloid where you have made a puncture. So those are just visual treats, but real thing is that this premacular cavity which forms is blood lined, while in the natural history of this resolution of subialam hemorrhage, almost always there is complete resolution whenever it happens. If it does not happen, that's a different thing. But when it happens, it resolves. The ILM goes back and sticks to the retina usually, and there is minimal chances of ERM formation. But if you drain the blood, then there is subialam cavity, premacular cavity, which tends to collapse over a period of time but may not collapse. In either case, there are chances of epiretinal membrane formation on the surface of macula. So that is something which we need to explain to the patient and tell him that you need to be in follow-up. I think we published a large series around 15 years back where we showed all these premacular cavities, and they are just visual treats. But anyway, in a very nice case, Apurva, and beautiful images. Thank you.
Thank you, sir, for the great points. Thank to all everyone. So we had a very great discussion on this Valsalva retinopathy, the management and the diagnostic features, the biomarkers. So congratulations, Dr. Apurva. She wins 2,000 rupees and this certificate for that beautiful image and the nice management of that case. With this, we move to the second winner for the month of February, Dr. Gaurang Sehgal. Dr. Gaurang is head of Sun Eye Hospital Group of Hospitals, Lucknow, UP. And this is sorry, the caption is wrong over here. This is the one vessel makes all the difference, ciliary retinal artery sparing CRO. Am I right, Gaurang? Gaurang, are you there? Dr. Gaurang? Dr. Gaurang, you are not audible. Dr. Gaurang? So, okay. So we can discuss this image. This is a case of central retinal artery occlusion with ciliary artery sparing. And he has put nicely the OCT image over there. We can see over there.
Yes, sir,
And
you're right, sir. It is one vessel that makes all the difference. Can you hear me?
yeah,
Am I audible?
yeah. Now you are
Hello?
audible, Dr. Gaurang. Please continue. You are muted.
Am
Unmute.
I audible, sir?
Yeah. Please
Am I audible,
continue.
sir?
Yes,
So sorry
Gaurang.
for the loss of connection. Yeah,
Yeah.
sir. So it is named as one vessel, which makes all the difference. So this is basically a 55-year a gentleman in the late 50s who presented to us with sudden loss of vision in one eye. The other eye had already been lost to a long-standing closed funnel RD, with the patient didn't get operated. So the presenting visual acuity was around finger counting close to face. And when we did saw the fundus and did the OCT, it was basically central retinal artery occlusion. But luckily, the cilio-retinal artery was patent. So this image has been captured on Mirante Nidec systems. And if you can see in the OCT beautifully, where the retinal ischemia has taken place, the inner layers have whitened and you can see the ischemia very well. But the area which is particularly supplied by the cilio-retinal artery, you can see the retinal architecture is pretty well maintained. And because of this, the patient had some useful vision. It was managed like a stroke emergency in my OPD. The patient was subjected to AC paracentesis, gonio massage. Since he was one-eyed in nature, we also tried some old unconventional like rebreathing in the same bag. And given he was given also Dimox to lower the intraocular pressure. Luckily, the patient gained some amount on 2 week follow-up. The patient has some useful visual acuity of 6 by 36 parts, and he's doing well till date.
Okay. Great. Dr. Gaurang, the left upper image that you have put it's what image this is near the OCT?
It's a red-free image, sir.
Red-free image only. Did you do FFA in this case?
I
FFA?
I wanted to. I was very tempted to do, sir, but the BP was actually shooting up. The patient had some 190 by 110.
Okay.
So even after multiple medications, the BP could not come. Yeah, but I was fascinated to do a FFA in this case for sure, sir, but I was not able to do it.
Great. Okay. So any comments from our panel? Dr. Mahesh, Dr. Muthu?
As he said, that it has to be treated like a stroke, and they are referred to. There are some places, I mean, many places have stroke clinics, so they can do a workup. Initially, in any case of central retinal artery occlusion, we used to do a cardiac evaluation. It is like a stroke. Actually, it should be sent to a stroke clinic rather than a cardiology evaluation.
Thanks.
I just have a point. You said fortunately the cilio-retinal artery, but I would say unfortunately that it did not reach the fovea. So anyway, he
Right.
had one, but it didn't reach the fovea. The second thing is just for a pathology correlation, that hemorrhage we see is something like a reperfusion injury at the edge of the ischemic and the
Agreed.
non-ischemic.
Yeah.
And
Correct.
also
Agreed.
the optic nerve seems somehow it looks quite compromised over there. Okay, now
Yeah.
just one small point now. There is a growing interest in which I have been also getting a growing interest in hyperbaric oxygen therapy. And these are the patients in which you have a split or a close to fovea involvement. Hyperbaric oxygen may, rather than a full CRAO, a partial or a foveal split CRAO could be, it could be an option. I've just done it in 2 or 3 patients now. I'm waiting for the long-term results. This is after hearing some talks in Delhi regarding the use of hyperbaric oxygen. But this would be, to my knowledge, something that splits the fovea very close to the fovea, the ischemic area. Increasing the oxygenation may cause that small amount of difference that is required to create some perfusion to the fovea.
Agreed, sir.
Correct.
Actually, for this case, I also consulted nearby hospitals for HBOT. But unfortunately, in Lucknow, I could not find a person who is giving HBOT. I was actually very much inclined to do that also because I wanted to use all the maneuvers which were in the book so
Yeah.
as to save some useful vision.
Chito, you
Uh,
can share the work done by you in CRAO, Chito.
Yeah, so no, that one, that is published in Kanski, but I also got a, comment from Dr. Dhananjay Shukla sir that can be a BRA also. But just to as everybody has told over here, we always, desperately want to give whatever maximum vision we can give to these patients. So this was during my Arvind tenure. We saw a case of a similar case. We did, gonium massage and AC paracentesis. Patient was a police officer actually, and smoking was the risk factor. And FFA, fortunately, you don't know, not always we do, but somehow I've done the FFA and we have traced the embolus. And post-operatively, the patient gained 6-9 vision, and we could trace the emboli. Those are dislodged, basically converting into a very BRO kind of picture. So point is very well taken. Every one of us, we try to give the maximum benefit to the patient in these eyes. And
Sir, I have a question for the panel, sir, if you may allow.
yes.
So, sir, this patient currently has about NS3 PSC cataract. Now, this is
Hmm.
a 3-month old case which when we are talking today. So, I wanted the expert opinion on when will be the right time to go ahead and do the cataract so the visual acuity might be improved. So, I just wanted the expert opinions, please.
Dr. Santosh or Dr. Muthukrishnan, please, can you please take this question?
I feel it can be done right away. 3
Yes.
months post occlusion, and if you have ruled out carotid and cardiac parameters are normal, and then we can take up a cataract surgery. Why not? After explaining prognosis.
Sure. Okay, sir. Sure, sir. Thank you.
Yeah. Dr. Santosh, your same opinion?
Yes, yes. Because if there's a significant cataract, it has to be done immediately.
Correct.
That will definitely.
Correct. So again, for the benefit of the audience or the viewers, they have a common question, sir, whether we should submit only the single image or the kind of collage or multiple images. So this image is a very good example of that. Whenever you are giving multiple images, don't make it, more than 3, 4, or it should not be a 6, 7 kind of image. Number two, it should be very much self-explanatory, like what he has put over here. Don't club so many images so that it becomes a kind of case report kind of thing where the brain literally has to struggle to identify what it is. So basically single image always preferred. If you are giving a collage image, then give the salient points where the viewer, whoever is seeing at a glance, he or she can definitely understand it. So this is for the audience and the people who are asking whether we should submit to the VRSA image competition single image or multiple like collage images. So again, congratulations, Dr. Gaurang, and he wins 3,000 rupees and the certificate. And with this, we'll move to the first winner for this month of February, Dr. Bipin Rana. Dr. Bipin is Associate Professor and VR Surgeon, INHS Aswini, Kolaba. And this is the beautiful image. You can see over here the vanishing golden fundus, Mizuo Nakamura phenomena in GRK1 associated Oguchi disease. So, Dr. Bipin, please
Sir,
tell about this
can you hear me,
case.
sir?
Yes, yes, very much audible. Please
Sir.
tell.
Sir, this was a good evening to all. Uh, he was a 6-year-old child who was brought by parents with complaints of night blindness, and when we saw there was a very nice this golden sheen was present, and so he was dark adapted for 3 hours, and after 3 hours we take the image again on Clarion, and so the color was completely changed. And after that, the ERG also confirmed this Oguchi's disease, and we sent the genetic testing whole exome sequences for the child and for the parents also. So the father was positive for this mutation in exome 7 in GRK1, and this mother was in exome 3 in GRK1, and the this patient was having mutation of both exons, that is 3 and 7, in JRK1 gene. So he was a compound heterozygous, and both parents, father and mother, were the carriers. So genetic counseling was done, where there was 25% of risk for the second child to be born with the disease, 50% chances of the carrier, and 25% of being normal.
Great. So in addition to the beautiful image, you have actually, gone further details into the genetic aspect. And may I ask Muthukrishnan, Dr. Muthukrishnan, to give his views on this image and the imaging technique?
A good image, quite a commonly seen image of Oguchi disease showing the Mizuo Nakamura phenomenon. Golden yellow tapetal sheen is well appreciated in this picture, and good to see that it was genetically proven. But have you done an ERG, a full field ERG showing normalization after 2 to 4 hours of dark
Yes, sir.
adaptation?
Yes, sir. Yes,
Very much
the same
diagnostic.
thing was done, sir. I mean, dark adaptation, and after the dark adaptation, also there was a change in the waveform.
Have you done it for the parents too?
No, not for the parents, only for the
Parents did not
child.
have this phenomenon, is it? Fundus was normal
No,
in the
no,
parents?
parents were absolutely normal
Okay, just carriers.
carriers.
Fine, fine.
So,
Okay, thank you.
How much
great.
dark adaptation did you require for the sheen to go away?
Three
Pardon, sir?
hours.
3 hours.
3 hours, he
hours.
told. Yeah.
Okay, fine.
So I'll tell one practical question. I don't have a Claras now, but during our Arvind tenure, I have tried for Oguchi disease. I am telling my where I have failed. So the Claras, the flash comes, it's little brighter one. So when I have tried after 3 hours or 4 hours, I was not able to, capture in all the cases this Mijo phenomena. I thought at that time whether the flash is causing something, like it is negating the effect of dark adaptation. What is the take of the panel or the seniors over here? Or Dr. Bipin, if you can.
Sir, may I, if you may allow?
Yeah.
Like for this child, we have taken image on the edon also, on the optos also. We have both edon and optos, but we don't have clarion. So clarion, I'm thankful to the Dr. Rupak Roy, Shankar Netralia. I have sent the patient to sir also for this image, and even for the second opinion also. So that the clarion had the best image out of these three. I have the picture of those also, but the best image was in the clarion.
Okay. Okay, so again, beautiful image, and congratulations, Dr. Vipin. He wins the first prize, the certificate, and 5,000 rupees for this. With this, we'll move to the month of March. Yeah, March 2026, and the third prize goes to Dr. Manu Sharma. Dr. Manu is MCH fellow, VR surgery in PGIMER Chandigarh, and this is the image, the visual corridor between two GRTs, for which she has won the prize, and this is the description Dr. Manu has given. May I request Dr. Manu to please say a few words about the award-winning image?
Good evening, one and all. Sir, I'm audible.
Yes, please continue.
Okay, so my case was 59 years old male. He was one-eyed, high myope. He presented to us with diminution of vision in the right eye, and on examination, he was having two giant retinal tears running parallel to each other, shown by black arrows, and there was superior retinal detachment, and the macula was on in between, and it was giving an appearance of a visual corridor in between the two giant retinal tears, as the name given by us. And patient was managed with scleral buckling plus pars plana vitrectomy and endolaser followed by PFCL silicone oil exchange. Thank you.
Okay, good. So with this, we'll come to our panel, and Naresh sir also, if we can take like scleral buckling, she told, and also we would like to know about the second, the PFCL assisted two-stage surgery. Like the role of scleral buckling maybe by any of the panel, and the role of two-stage surgery by Dr. Naresh sir.
No, I won't do buckle for this case, Chittaranjan.
Yes, sir.
Yeah, so I'll go for vitrectomy. Plus, sir,
Sir,
Not, I think
240.
not a scleral buckle, it's bell
Sir,
buckle,
240
insertion
band
band.
was passed.
240
Scleral
band.
band.
240 band.
Yes,
okay.
band. To
Otherwise,
support the vitreous
also,
space.
no, otherwise also, I don't find any reason for putting a band or even 4 band, 42 band in GRT cases. I don't think it serves any purpose because most of the time the vitreous is detached till the ora in these cases. So I think a primary vitrectomy should be fine in all these cases. We don't use, almost for the last 20 years, we have not been using any belt buckle for any of our GRTs.
The patient was phakic and we were not able to cut the anterior vitreous.
No. Fake kick,
So,
with all our wide angle viewing system, even in fake kick, it is not that difficult to go to the ora actually, up to the ora. So we have to calculate the cutter, but it doesn't touch the lens that often.
I agree with Dr. Manu that these cases I myop one eyed. I always support in the periphery with a encircling band, and then because whatever said and then the complete vitrectomy may be little difficult and severe chances are there, especially in inferior GRT. So it is just like reinforcing our treatment. That's all. This specific case, one eyed, high myop, inferior, everything. Otherwise, managed well.
So one additional point to that is that if you have to put a belt buckle, the rule is that it has to be a very shallow buckle. Anything hard can cause an opening
yes,
edge of the
slippage.
horns. And
Yes.
one very interesting thing in this image is that you can see a blood vessel crossing over in a slight, it looks like a tag over there. And that is comparatively, it doesn't happen in a GRT philosophy where the anterior edge is pulled off. The anterior lip is pulled off. So you see a bridging vessel over there going, which is again a little bit of a different attitude, different thing happening. I was a big proponent of the short-term tamponade of PFCL, especially if it's a double GRT. I like putting a short-term PFCL tamponade 2 weeks, nil positioning, and then come out with air or gas after that.
Okay, so all the points very well taken, and just to summarize that a kind of band in addition to primary vitrectomy is reserved for a small special number of cases like high myopia, one-eyed, phakic, and all. Otherwise, in general, we go for primary vitrectomy in these eyes, and they do well with this. Also, the risk of slippage, retinal slippage is there. So, buckle we don't do traditionally in all the cases. That is the point taken from over here. Very well discussed. Again, congratulations, Dr. Manu. This is the certificate and 2,000 rupees you wins for this nice case and nice management of the case. And with this, we come to the second winner, Dr. Abhishek Gupta. Dr. Abhishek is Associate Professor in AIMS Kalyani and Senior Vitreoretinal Surgeon. And this is the image for which he has got the award, a motile subretinal cystic circus. So many clappings for Dr. Abhishek. So Abhishek sir, can you please describe the image?
Good evening, sir. Am I audible, sir?
Yeah, audible. I will go to the next.
This image, so this lady, 35-year-old lady, she presented to us with sudden onset diminution of vision in left eye. She had anterior uveitis.
Yeah, I think I'll go to the next. Manjula madam, can you please help? The clapping is coming again and again. Or maybe I'll just change the. Manjula madam, are you there? Can you please help in this? That clapping sound is coming. Can you help in this?
We'll check the PPT.
Okay, we will stay at this phase. Abhishek sir, you can continue.
So this 35-year-old lady presented to us with sudden onset diminution of vision in left eye. So on examination, vision was 360 and she had anterior uveitis. So on dilated fundus examination, there was vitritis and there were two subretinal cystic circus sac superior nasal to the disc. So So it was just a normal subretinal cystic circus which we had seen before. But just I took the photo. So this picture is around 12 years back in my PG days, around 2014. So it was taken from that camera. So when I took the first photo, you could, as you can see in picture A, so a scolex had protruded out. So then generally we take 2-3 photos. So on second photo, that scolex had protruded to the edge of the sac, and in third photo it has totally retracted into the center of the sac. So this I was not expecting because I had not seen anything like that before. So, and actually I said what I was taking. So on analyzing all the serial photos, so I realized that just fortunately I had documented motile scolex which was protruding outside the sac, and then it was retracting back upon light stimulation. So then I showed it to my teachers, and then this case was taken up for pars plana vitrectomy and aspiration of the subretinal cystic circus sac and excision with the cutter. Fluid air exchange was done, and that site was endo-lasered, and it was gas tamponade was given. So post-operatively, the retina was fine, and the vision improved to 6/12. So this is the case which I shared in this competition.
So
Thank you.
I'll just quickly go through the slides because of some technical problem. The clapping is coming, but just to add that Abhishek has, published this image in the Eye Journal as a clinical image. This is the image what he has described, and we'll move to the next. So congratulations, Abhishek sir. He wins second prize and 3,000 rupees for this beautiful image. Then coming to the first prize winner, Dr. Supreme Goel.
I have a question.
Yeah. Yes, sir.
Hello.
Yes, sir.
No, this clapping noise is coming. No, I have got a doubt actually. Can you stop that clapping noise?
I'll stop and again I'll share, sir.
No. You go to the other image where there is no noise. Other slides.
No, that is coming again.
Okay,
I'll stop and I'll again reshare.
Yes, doctor.
Okay.
Okay.
Now, in the meantime, we can discuss. Chitranjan, I have a genuine doubt.
Yes, sir.
No. Like the northern part of India is predominantly, they say, is vegetarianism. But we see more what you call species, of course, is reported from the people who are consuming more vegetarian than the southern part of the country. Is it because of the contaminated vegetables or what? Because you have also reported.
I also agree with that. Kerala is 100% non-vegetarian. We don't see sexual purposes. In 25 years, I have seen only one case.
Yes, it is rare in Tamil Nadu also. We have come up, but once in a year or once in 2-3 years.
Yeah.
But
So
in
very rare.
part, it's quite common actually.
Absolutely.
Maybe Dr. Vinod can throw some light actually regarding his experience in RT Center.
Vinod is here?
That Vinod is there. I don't. So, I have the share sound I have deactivated so that sound will not come. I'll go to, sir, should I discuss that image or we'll go to the next image?
Vinod can comment anything regarding the prevalence in northern India. Vinod?
Yeah. Vinod, sir?
Not there, I think.
He's not there.
Okay. Anyway, otherwise, in fact, I just went through the American Academy iWiki. The similar picture is given by Vishali Gupta madam, contributed by Vishali Gupta madam in iWiki. That picture is there in American Academy website. So I think it is all from India. And Jay Chabalan is one picture. These are the two pictures in American Academy regarding purpose.
This is coming now. That's like, sir, sorry for this technical thing. It is not there. Okay, so the first prize winner is Dr. Supreme Goel for the month of March, and she is VR fellow in Chaitanya Hospital, Trivandrum. And this is the beautiful, OCT image of the myopic retina, which he has captured as built-in sets anatomy playing tricks on OCT.
Good evening, sir.
Yeah, Dr. Supreme, please.
Am I audible, sir?
Yes, please tell.
Yeah. So this image was captured by Interlight machines, web source OCT. This is a case of 29-year-old pathological myopic female. She underwent belt buckling and VR surgery with silicone oil installation 9 years ago, followed by silicone oil removal. And now she was on constant follow-up since then. And now she had SRF at macula and VMT and nasal tractional schisis. And this image, it is actually not at fovea, but it is away from the fovea. It is showing the residual vitreous membranes, which are causing tractional schisis here. And then she had to be taken for resurgery to relieve these traction. And then she underwent membrane peeling, endolaser, fluid air exchange, along with silicone oil installation.
Okay, great. So initial surgery, what tamponade you used, Dr. Supreme?
The silicone oil only, sir, 1500 CSC.
Okay.
She underwent surgery for subtotal regmetrogenous retinal detachment. And she has axial length of 30.56 mm. So like.
Okay. And this is Interlight, right?
Interlight machine, sir. And also, sir, she is
Interlight,
a known case of bronchial asthma. And recently her cough worsened. So, like, she was stable for quite long, like 7, 8 years she was stable. But recently, like, cough-induced vitreous separation, like, we were thinking that cough-induced vitreous separation happened and which propagated this retinal detachment, like this tractional element.
Correct. Any points, Unni, sir, regarding this case?
I think the main learning point here is that in a myopic patient, however much vitreous you remove, there will be a sheet of vitreous. Sometimes you need to spray it with IVTA and after you think the job is over, there will still be one more layer. After you think the job is over, there still might be one more layer. And it has brought it out very well. Years later, that particular vitreous has contracted, may or may not be the cough, but it has contracted and you see focal tractional areas happening. So like you said, philosophically, it looks like a pair of shades, but probably, and what do you say, maybe not looking properly in the first surgery is what caused this slight recurrence.
So multiple times vitreous staining and removal of the cortex, that is what we advocate.
Yes.
Yeah. Any other points by other panel?
Was there only traction or recurrent regarding came back with this, or only traction at the macula?
So there was no break identified at this at this presentation.
Only traction at the macula. Okay.
Yeah, residual membranes were there. And even during the resurgery, like it was difficult to remove these residual membranes because of such high axial length, 30.56, along with posterior staphyloma was there.
It is difficult to reach the posterior fold. That is another thing.
Yeah.
So that's why in the previous cervical ground probes that Egyptian surgeons, they were telling you can make the sclerotomy 6 millimeter posterior to the limbus. So little back. Even that will not go through the retina and you will reach. And some people have advised without rocker directly go inside. Lot of things to reach the posterior fold.
Do it under hypotony so that you can push the sclerotomy sites.
Exactly, hypotony.
All those things. But one interesting thing, I think in the VRSI meeting, I think Dr. Naresh was also there, using a finesse loop. Because it is longer, it will reach with the loop stuck out. It can also reach and kind of gently tackle these membranes sometimes, depending on the visibility and hardness.
But the only problem is it should be a fresh fitness loop.
Yeah. Yes, absolutely. The same discussion came that day, not recycled so that it is smooth.
Exactly.
No, sir. Can you again repeat, sir? Unni sir and Naresh sir, what is the problem with this
The fitness loop should be used for the first time.
Yeah.
Because it's
not a repeat.
Serrations.
Not a reuse one. Okay, correct. So any point about sir, gas versus oil in these eyes? Naresh sir or Mahesh sir, Unni sir,
I don't know, we are
Muthukrishnan?
feeling safe with oil because in case if the redetachment happens, the PBR under oil is much, much lesser compared to
Less, correct.
the
PBR is
PBR
more
under
in gas. Yeah.
gas.
Agree. Agree.
Okay. Okay. So again, congratulations, Dr. Supreme, and this is the certificate and 5,000 rupees he gets. So congratulations to all our winners. And with this, I'll stop sharing and I'll request Mahesh sir and Naresh sir, Unni sir, everyone to please encourage the winners and to please put a word for submission of more good quality images for our competition.
Chitranja, I have already spoken. You can ask Dr. Mahesh and Dr. Uni to give the conclusion remark, and we are over by 5 minutes actually.
Over by 5 minutes, yeah.
Yes.
Unni.
Yeah, so I would just like to say that if you look at something, getting a recognition is the fuel to put more images. So that is what all the winners should be communicating to their friends and colleagues and fellows, that they have been recognized and their image was discussed and it was a good meeting, so that more and more people get into that that I wouldn't say habit. It is more like an affliction or a or an addiction to send images. That should be the aim. But I would like to thank the VRSI Chitranjan especially for the valuable discussion that is going on here. We're not just discussing the image, we're discussing the very valuable tips in a very short period of time.
I
Dr.
agree,
Mahesh.
Unni. Actually, yeah, this when we see a picture, a spotter especially, and we will remember these few points so this will be useful for our practice. A nice discussion, conducted by Chittaranjan. So I, I am putting in all the groups to people to keep on. I mean, contribute to the VRSI image for competition. So, yes,
Yes,
Chittaranjan
sir.
for
Chitranja, we will
concluding.
commemorate our 50th.
Yes, sir. Yes, sir. No,
Next,
By cake cutting.
Cake cutting. No, yes, sir. That is a great thing. Uninterrupted. We have done it, as Naresh sir told, more than 50 months because our tenure when I was executive member, 24 months. Before that, 24 months, and now it is 3 months
3 months.
over.
So
Like
51st month it is.
yeah, 51st month. So congratulations to all of us. Thanks to all the EC members of VRSI, all the seniors, and special thanks to team Numeratech, led by Manjula Madam, Sai sir, and their team. They are actually putting a lot of effort to make this happen. And congratulations again to all the winners and to all our viewers. Please keep on submitting good quality images. You have seen these same images have been published. Also, you can get it published. So please submit, please enjoy the academic and the photographic and the philosophical aspect of the retinal images. So with this, if there are no further comments, we'll close the ceremony. Thanks all.
Thank you. Thank you.
Thank you, sir. Thank you, everyone. Bye-bye.
Dr. Mahesh, Dr. Mahesh, thank you.
Thanks.